Good afternoon, everybody. My name is Mike Willett at the Intertribal Council of Michigan's National Native Network. Welcome to the National Native Network webinar series on cancer risk reduction in Indian country. This webinar is titled, Did Our Ancestors Eat Buffalo Chicken? Decolonizing Practices in Urban Indian Health. This technical assistance webinar is being hosted by the National Native Network, which offers technical assistance and resources for commercial tobacco prevention and control throughout Indian country, and the Indian Health Service Clinical Support Center. Your presenter today is Kerry Lessard. She's a Master of Applied Anthropology and is the Executive Director of Native American Lifelines, a Title V Urban Indian Health Program with locations in Baltimore and Boston. An applied medical anthropologist, her work focuses on issues related to the nexus of historical trauma and the health status of contemporary Native people, responding to the unique needs of urban Indian people. Native American Lifelines applies decolonization theory and trauma-informed care practices to deliver culturally centered health and prevention programs to intertribal population struggling with intersectional health and socioeconomic disparities. We are pleased to offer continuing education units for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated 1 credit hour for nurses. To obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey that we will be issuing out immediately following the webinar. By the end of this webinar, participants will be able to conceptualize the link between historical trauma and contemporary American Indian health outcomes, employ successful community interventions around topics of food sovereignty, decolonized eating practices, and overly indigenous strategies to combat significant health outcomes in Native communities such as diabetes, cardiovascular disease, obesity, emotional health, and resilience. Create culturally grounded health and wellness programs appropriate for and desirable to the specific needs of their communities. If you have any questions, please type your questions into the question box on the lower right side of your screen in the GoToWebinar platform. Questions will be answered during the last few minutes of the webinar. And at this time, I am throwing it over to Kerry Lessard.
Okay, well, thank you very much. Good afternoon, everyone. I appreciate you joining us. My name is Kerry Lessard. I am a Shawnee woman and a medical anthropologist, and I'm the Executive Director at Native American Lifelines, which is a Title V Indian Health Service contract site in Baltimore as well as in Boston, Mass. Today I'm going to speak about the ways that we in our program apply decolonization theory within health programming that is specific to our urban Indian population. So at Lifelines, our practice necessarily deals with the distinct cultural needs and priorities of Native people. It's been really important to us that when we develop health promotion, disease prevention interventions, that everything that we do is centered within shared beliefs and cultural concepts that are appropriate to our community and our community members. And while I'm sure that most participants are familiar with concepts of historical trauma and trauma-informed care, I will talk about these ideas today in ways that are specific to the application of medical anthropology. And to make sure that we're all on the same page, when I speak of medical anthropology, I'm speaking of the place where culture and health intersect, the way that culture informs health decision-making, what we believe makes us well, what makes us unwell, our history as a people within the healthcare system, and how all of these things shape the ways that we access care, the ways that we experience barriers to care, and the types of treatments, medical treatments or otherwise, that we will accept or reject. And I would imagine to most of us it seems obvious that responding to the cultural needs of a people is crucial to an effective healthcare or HPDP practice. But mainstream providers often take that for granted, and not surprisingly, it dictates how well or comfortable we feel with providers and the extent to which we engage with them. So while I'll give the example of a food sovereignty indigenous foods project here, I hope these ideas and models can get you thinking about ways to integrate culture into HPDP interventions where you are. And I'm sure we already do this, but this talk today I hope will provide you with some theoretical paradigms that may be new or unfamiliar to you that will make your program sound from a social science perspective. And of course, our funders love when we do that. I also want to say here that this presentation is one that I adapted from a paper presented at the Society for Applied Anthropology. So if this feels like it has a more academic tone, that is why. Okay, so I'll start with some history on the Office of Urban Indian Health Programs. During the 1950s and 60s, the BIA relocated over 160,000 Native people to selected urban centers across the country. In the late 60s, urban Indian community leaders began advocating for health programs that were specific to our unique social, cultural, and health needs. In 66, and in response to the efforts of those leaders, the IHS piloted an urban Indian health clinic in Rapid City, South Dakota. In 1973, Congress appropriated funds to further study unmet urban Indian health needs in Minneapolis. And the findings of that study documented the barriers to health care and led to additional appropriations under the Snyder Act that would support emerging urban Indian clinics in several of those BIA relocation cities. So in 1976, Congress passed the Indian Healthcare Improvement Act, ICHIA, Public Law 94-437, Title V of which targets specific funding for the development of programs for urban Indians. And since its passage, amendments to Title V have strengthened the programs that the UIHPs are able to offer, expanding to direct medical service, alcohol and substance abuse services, mental health services, HIV services, and health promotion disease prevention programs. And here you should see, this is a front of our building in Baltimore City. Native American Lifelines delivers outreach and referral services here, as well as direct dental services and behavioral care and culturally driven HPDP programs. In Baltimore, we represent just 0.4% of the total population. And while Indian Health Service clinics and hospitals are available on reservations, and as noted prior, in some urban settings, like big places like Seattle, they have a huge Indian Health Board, this isn't always the case. And that means that the care guaranteed to us as Indian people through treaties and in exchange for divestiture of lands ceases when our address changes. So in that regard, urban Indian health programs like ours serve as vital safety nets, but even these are limited in terms of scope of services offered. And I would say that that is probably the single biggest type of call that we receive here in our office, given our proximity to DC or Rockville, where the IHS headquarters is located. People may come into work in these federal jobs from, let's say, Tuba City or Pine Ridge, and have become accustomed to having health care accessible to them, and we just don't have that in that area, in this area, so it makes it kind of challenging for us. Okay, so who is an urban Indian? I'm going to use some definitions provided by anthropologist Susan Lobo, and she offers a way of thinking about urban Indians in kind of 4 distinct categories. Long-term residents would be people like my family members who have for generations resided in one primary urban setting. Forced residents are Native people who were part of the termination and relocation policies that occurred between 1945 and 61. Permanent residents are those who may have relocated for work or other opportunities and simply stayed. So that description really fits the Lumbee population that we see a great deal of here in Baltimore. And finally, medium and short-term residents, that term reflects the fluidity that can be seen in those who move back and forth between their territories or from one urban location to another. And again, that's a great descriptor for the folks who are just here in the area working for IHS, BIA, NCAI, what have you. Okay, so Lobo also notes that these individuals, urban Indians, are identified by ancestry, appearance, culture, and community participation. I have a bit of an issue with the second and third categories of identification that she has here, and I'll get back to that in discussions of historical trauma later on. But nevertheless, the 2012 U.S. Census estimates that there are 5.2 million American Indians, Alaska Natives, either alone or in combination with another race, representing 2% of the general population. 22% of these individuals reside on reservations or other trust lands, while 60%, and actually we believe, and I'm a board member on NCUI, the National Council of Urban Indian Health, we see numbers that are closer to 70% living in urban areas. Keep in mind that while the majority of federal funding goes to reservation communities, which I'm sure you all know, the majority of Indian people actually live in cities or other non-reserve areas. So the funding is really kind of lopsided to where the people are. Among this number, there are 567 federally recognized tribes. This doesn't count state tribes or unrecognized tribes, all of us with distinct histories, cultures, languages, and belief systems. And in UIHPs, we're kind of unique in that in addition to just enrolled members of federally recognized tribes, we are also able to see members of state recognized tribes and descendants of either one of those groups. But based on the diversity that we're talking about, one size fits all doesn't work for us. Unfortunately, what is true across the board is that American Indians and Alaska Natives experience more poverty and depreciated health status than the general population and even other minority groups. And here's a picture of some of our community members participating in our culture class program. At our site, we do our best to meet the multiple needs, multiple health needs, multiple social service needs of our community. But in recent years, we've made an effort to focus on our youth. And to do that, we offer what you're seeing here, which is a weekly culture program. And that focuses on reconnecting youth with a sense of Native identity and shared belonging. And it gives us the opportunity to kind of talk with them early, not just about their history and identity as Native people, but also to kind of focus on wellness and help them kind of avoid some of the issues that are seen within their families. In our families, it's true for me as well. The children in our community do grow up in environments where intergenerational substance abuse is present and parental absence is present. And it's not just present, it's ubiquitous, unfortunately. And that in turn limits the availability of adults in the community, and so children become even more disenfranchised from cultural activities and from transmission of traditional teachings and values. I was very fortunate to be raised with my grandparents, and they taught me things, but that is not true for a large number of the children that we see, and that's even true of adults. So in my career as an anthropologist, what I am most interested in knowing is why this is the case, the intergenerational substance abuse and disenfranchisement. And specifically, I like to explore the role of historical trauma in the contemporary health status of urban American Indians. And when speaking of historical trauma, I refer to the definition provided by Lakota scholar Maria Yellowhorse Braveheart. And she describes that as the cumulative emotional and psychological wounding over the lifespan across generations, emanating from massive group trauma. And practically speaking, we can think of these traumas in terms of loss of land, loss of agency, loss of language, loss of traditional subsistence practices and ceremonies, and even the loss of control of our own image and identity. And that is something that those of us living in the DC metropolitan area know a little something about. So often we think of this as kind of a cultural PTSD. Joseph Gahn, and I've put his definition here, he elaborates on this, talking about the loss of language and culture that has left so many Aboriginal people bereft of their unique place in the world. So really left us sometimes unrooted or unpeopled. And it is these disorientations and their psychosocial correlates that the term historical trauma was intended to capture. So while historical trauma is commonly viewed as a consequence, or not even commonly viewed, but some people just think this applies mostly to folks living on the reservation, it's also very apparent in urban Indians who, as Irene Vernon and Pamela Jumper Thurman observed, may feel even more disenfranchised from their culture or identity as Native people. So the picture here is a kind of funny little picture, and we talk about the food program. It may make more sense, but you know, we were talking about how kind of New Agers or people, at least on the East Coast, make up these crazy Indian names for themselves. So we joked about what if fortune cookies, you know, gave you your Indian names. So we made little fortune fry breads that have crazy Indian names in it. So it's a tongue-in-cheek joke that probably is mainly funny to me more so than anyone else. But anyway, in thinking about these things that we just talked about, the historical trauma and the way it impacts health, I have come to conceive of historical trauma as a syndemic condition, and that's something that medical anthropologist Meryl Singer conceptualizes as the aggregation of two or more diseases in a population where some level of positive biological interaction exacerbates the negative health effects of any or all diseases. In that these are often thought of within the context of social determinants of health or health disparities, and for us and other urban Indians, I would say it's poverty, stress, structural violence. I think of historical trauma in the same way, that in the same way historical trauma contributes to the burden of disease for Indian people. So when we think of co-occurring or comorbid conditions like HIV and hepatitis C, I kind of think of historical trauma as something that often co-occurs with substance abuse, depreciated mental health, chronic illness. And so this is the way that I think of that trajectory, the getting from the historical trauma to the contemporary health status, that exposure to the kinds of traumas that we face as Native people can lead to health-demoting behavioral practices. And I'm talking about, for instance, drug and alcohol abuse that can kind of mute the intensity of those traumas for you. And then the way that those behaviors increase risk of exposure to additional negative health outcomes. Those could be contracting an STI, placing oneself at risk for intimate partner violence, incarceration, the things that amplify conditions of poverty. So in terms of human costs, and certainly what we see in our community is a diminution of self-concept and a loss of resilience, and a feeling of being isolated from the rest of the world by virtue of this cultural and historical dissonance. And I would say that in our community, and this is certainly something that's been voiced by members of the Lumbee population here, that they not only feel disconnected with other populations, but they feel disconnected from Indian country as well. Here's a photograph of someone that I co-write with. This is Pyramid Lake Paiute artist Greg Deal, and a performance art piece that he did called Red Skin, kind of exploring historical trauma and microaggression. And I think just this kind of tongue-in-cheek way of looking at colonialism and romantic nationalism, that really well expresses the way that non-natives think of us, and the really limited and flattening way that their understanding of us can make us feel. And for urban Indians, this can be particularly acute. So if we go back to Lobo's discussion of how we identify urban Indians, I think her criteria of appearance and culture can be problematic. You know, we don't in cities often or we don't always intermarry with other Native people. You know, we don't look like the stereotypical Hollywood Indian. And because of the conditions of historical trauma, Native people can find themselves swallowed up by an environment that renders them practically invisible. So you may want to keep cultural practices alive, but you find that policies and social structures are instead designed to rupture the normative indigenous cultural processes. And with regard to appearance, you know, and control of identity, we live in a society that claims for itself the authority to adjudicate indigenous identity and to dismiss Indian voice. And so the issue of the Washington NFL franchise and its defenders is probably the most relevant example. Here, Native people are daily reminded of their position within settler colonialism, and often their resistance is countered not with discourse on the merit of our arguments, but rather a critique of our identity. So if you say, you know, that mascot really bothers me, what you're likely to get back is, well, you're not a real Indian, or how much Indian are you, or my favorite one, well, I'm part Cherokee and none of this bothers me, and so it shouldn't bother you. So in short, if you don't look like Disney's Pocahontas or the guy on the side of the helmet, then your identity claims are suspect and you can't do anything about it. And so the idea that that authority, the authority to say who you are, that rests with dominant society, can be another function of historical trauma, and that's something that we definitely hear voiced by our community members. So to mediate these effects, we here at Lifelines are strong proponents of the idea that within our cultures lie the means for health, wellness, and healing. And we've made a conscious decision to rely heavily on activities of decolonization, essentially returning to the community those beliefs and practices that kept us strong and formed the core of who we are as a people. I shared Jeff Corntassel's definition here. He's a Cherokee scholar out of UVic, I believe. One of the things that really got me thinking about how we identify ourselves as Indigenous people, how I know I'm Indigenous and how I communicate that to others, was reading his article, Re-Envisioning Resurgence. And I recommend that you read it. It's an open access article from the online Decolonization journal, and I included that link and some other links in the resource guide that I gave out, just extra things if you'd like to read to know more about either historical trauma, medical anthropology, or how these can relate in public health forums. The big takeaway here for me was Corntassel's discussion on how our relationship with land is our primary way in which we know and signal our indigeneity. And again, land being really crucial to that. So if we think of historical trauma as something that creates illness or lack of wellness, right, if the loss of culture and language and subsistence practices create conditions of unwellness, then it only makes sense that if we restore what was lost, we can reestablish the conditions under which we can be well. And this is something that Vernon and Thurman refer to as retribalization. So I want to share a story that illustrates both the idea of historical trauma impacting health and how we apply decolonization theory to address that, and sort of where Corntassel's discussion of our relationship to land comes in, and where we get the title of this presentation. So one evening in our culture class, one of our kids' aunties was talking about how she recently watched Dances with Wolves. She knows that I have relatives that live on Pine Ridge and Rosebud, and she, wanted to talk about that. And she was really fascinated by the scene where Wind in his hair reaches into the freshly killed buffalo, pulls out the heart, it's still beating, and bites into it. And she's describing this really vividly. And her nephew looked up from his drawing and said, "I love buffalo. It is so messy and it's so spicy, but man, I love it." And we were like, well, when did you have bison to eat? And we asked some more questions, and we realized that he was talking about buffalo chicken. This young man had no idea of the difference between the fluorescent orange chicken served out of styrofoam containers and the vital food source and cultural fulcrum that bison is for Plains people. And talking further with him, we became aware that he had no idea where his food comes from. And that was really, that freaked us out, that a native child and a child from a tribe whose people are farmers, that he could become so disconnected from land and from food production. It was really shocking to us, and it raised a larger question. What do our urban Indian children know of traditional foodways, and how these foodways have always formed the basis of who we are, how we live, and how we maintain wellness? And so our kids are real familiar with this, right? And these are pictures from the neighborhoods in which they live, but they know less about this, or, come on, slide, that, or that. I'm the queen of ubiquitous deer photographs, so I'm sorry that in that rush you didn't get to see them. So anyway, identifying this need that, right, our kids didn't know anything about how food was grown, where it comes from, we started a container garden program. We talked with our kids about the kind of foods that they ate and what they thought might be indigenous foods. And we defined indigenous foods for them as things that our ancestors might have hunted or grown and eaten. And so some kids were really quick to name corn and berries and beans as traditional native foods, but others weren't so sure whether or not mac and cheese was something that we ate traditionally. So we talked about how food is grown, about seeds, and about the difference between seed saving and the chemically treated seeds that most people use. And so that allowed us to have an age-appropriate discussion with our kids about food sovereignty and decolonizing the diet. Now, our kids face multiple challenges, but what they understand from us week after week is that, when we're together on Thursday evenings, we are sharing space as Indian people, and this identity is important to who we are. So for them to consider that what they were eating, what they were planting, were things that their great-great-grandparents might have eaten, they thought that was pretty cool. So they decided what they wanted to plant, and here, with the exception of morning glories, the greens are something really popular in the Lumbee community and something that those folks would grow. They chose what they wanted to plant, had some prayers, planted our seedlings, and this really started the journey of reconnecting with land and food and heritage and ceremony. Okay, so there's some more of our plants later on in the process. And there's some more of them. Okay, so when our seedlings were about ready to be transplanted, our kids painted pots with designs that were meaningful to them. And this was another way, we're very fortunate to have an artist who is on staff here, but also participates in our programs with youth, and, talked with them, about the connection between traditional arts and function, that, we were a people that have, beautiful crafts, but they also serve a functional purpose. And so our kids had hands-on experience approximating the practices that accompany traditional food production. So it wasn't just getting foods in the ground. It was kind of more of the spectrum of imperfectly, but the spectrum of how our people would create a culture around our food and food systems. We also use this opportunity to slip in a little education about tobacco, its ceremonial uses, and what constitutes abuse. And we actually have tobacco plants that are growing, and this is, again, a photograph of our center. To bring it home, our kids now understand that if you don't have to sing a song when you purchase or you light your Newports, it's not traditional, because the discourse in this community is, I smoke because it's my culture. And so we hope that getting our kids to think this way will prevent or delay initiation of commercial tobacco use. What I can tell you is that it's been effective at getting some of their parents really pissed off with me, because their kids come home and give them grief. As in many other cultures, sharing food is an important part of belonging. It connects us with our past, with our stories of who we are as a people, and how we're in relationship with one another and to the land. You know, our kids don't live a Brady Bunch kind of life. They don't normally sit down to a meal as a family. What family is may be constantly shifting for them. And so our practice of sitting down and eating together has become extremely important to them. And when we don't do it, they get really upset about that. And this allows us to have important conversations, silly conversations, but mainly, you know, we just are with them and they're with us, and it's very special to them. And so we're creating, again, we're creating culture around food and the growing of food, or not even creating, but just renewing those practices. So one of the kids' favorite parts of this connection is preparing the spirit plate. I don't know if there are any non-natives on the call, but it's an offering that we make and have prayer over before we sit down to eat. It's you know, a bit of everything that we have that we take outside and leave for the ancestors. We do have an elder in our community. She's someone that tells a lot of stories about food. She is a White Mountain Apache, and she will, you know, take the spirit plate out with the kids when she can. And again, we're in the city, so sometimes the spirit plate attracts the attention of critters, mainly rats and feral cats. And so, you know, she would tell them that, well, sometimes the spirit comes in the form of a cat or a rat, but it's still praying, and it's all good. So now that cats, I think, have, you know, kind of conflated spirits with cats. I don't know that that's necessarily what we want to do, but it is what it is. As a result of these activities, children on our program can now identify indigenous foods, and they connect those foods with their indigenous identity, and they truly enjoy eating them. That's my nephew. He's so handsome. So by starting this one little project, by planting seeds, by you know, knowing that our kids didn't know where their food came from, our community was able to reconnect to important aspects of our identity as Indigenous people that transcend simply eating cleaner, healthier foods. And all of that is important. We know that obesity, hypertension, type 2 diabetes, those things are, you know, all in certainly medical anthropology lexicon are talked about as the diseases of colonization. We know that that's important, but, you know, creating these other kinds of culturally vibrant connections are important as well. So one of the connections that we think is important through this program is strengthening connections with the land. So getting our kids' hands in the soil and helping them to see, you know, how food is planted, for them to watch it grow. That gets back to Corn Tassel's idea that, you know, our relationship with the land is something that informs who we are and lets other people know that we are Indigenous. It strengthens our connections to culture. So our kids are able to understand, you know, again, they may hear stories about First Strawberry or about Three Sisters, or they may learn different ways of food preparation. The elder in our community makes tiki bread, and so, you know, that's a different way of cooking that they might not normally be exposed to. This fine-looking young gentleman is known as Buck Owens, another ubiquitous deer photo. Respect for our relations. So, you know, whenever we're serving any type of meat to our children, whether it's venison or bison or chicken or, you know, whatever it is, they know that that is a life that sacrificed itself for them and for their benefit. And so, you know, we don't waste food here because that is seen as disrespectful. And that we, for the last 2 summers, have participated in the summer food service program as part of USDA, and waste is a big problem with them. So they were really excited to hear that, you know, our kids are kind of inclined not to waste food, and this is the reason why. it allows us to strengthen connections to ceremony. So, again, not just the ceremony of planting or harvesting, but the activities that we engage in around food. So if we have, let's say, a graduation, we will have a feast and an honoring for that. We use our time together to talk about, other events that we want to commemorate, whether they're positive ones, or we talk about, we observe the anniversary of the Indian Removal Act and talk about what happens to kids there, because a lot of our kids are from southeastern tribes, or the occupation of Wounded Knee. Those are all opportunities that around the dinner table we are able to talk about our history as a Native people, our ceremonies, and some of our kids are probably better educated and more aware of American Indian history than some of their family members, and that's something actually that the adults and their families do appreciate. It strengthens connections with our ancestors. So when we engage in activities around food productions or stories around food production, that is a connection between our past, and we kind of talk with our kids about sort of being centered in that process. So it's always a reiterative process between our ancestors and then ourselves, and then thinking forward to the generations yet come into being, that the things that we do now are relevant to both of those places, and certainly how we engage with land and our health. And then strengthen relationships with our elders. We do bring elders in to, talk with the kids in our community. This is our Apache grandma who tells the stories. But again, these are kids that may be in their homes, they don't have both parents, they may not have any of their parents, they may not have elders around, they may not have healthy and functioning people. And so when they are here with us, they are surrounded by adults and elders who are present with them and invested in them and engaged with them, and who show up for them. And that is something that we think is really important. So here, it helps us to strengthen our relationship with our children. And here, one of the adults in our community is participating in crafting with one of the kids in our community. And then our kids have a stronger Native identity. And, when you look at studies on resilience, or even some of the discourse surrounding mascots or stereotype, when children have a strong and affirmed sense of identity, it really helps them to have better behavioral health outcomes. This is not at all without its challenges. Indian Health Service, for example, has told us that it doesn't fund culture programs, and it wants to see more evidence-based programs, or EBPs. And that's fine, but these rapid assessments, while they're possible and they're valid in their own way, certainly, they lack the longitudinal focus of ethnographic engagement. And the latter is really something that feels more authentic to the way that Native people understand their lives. The whole kind of hit it and quit it, that, you're just in a community and out of it, that hasn't traditionally worked well. Our people bristle to the kind of white saviorism that can be implied in top-down interventions. The woman who runs the Urban Indian Health Program in Missoula, Leanne Brucehead, said something once that really stuck with me, that, you tell us EBPs and, all this kind of stuff, but you are expecting our cultures to fit into your little box rather than having your programs fit the way that we live. Because the way that we live, what we do in our homes, that is what is truly sustainable, not a mold that we are kind of forced to fit ourselves into because it's what the funder demands that we do. And so with interventions that don't come from our communities, kind of theft of agency really replicates the colonial relationship, and it exacerbates the impacts of historical trauma. And this is in no way to say that anthropology, has all the answers, or that it's without its own baggage, because, hello, Vine Deloria Jr. totally does have lots of baggage. But I do feel that as anthropologists and medical anthropologists, we are well positioned to work with communities in articulating their own priorities and addressing them in the most appropriate ways possible. And I would say this is true for any of your programs. Your communities may or may not be like Baltimore or Boston. You are the experts in your own communities. You talk with the families, you know what their concerns are, what their priorities are, and you know best what they want, and you know the most appropriate ways to convey health promotion, disease prevention messaging, and to develop interventions that your people not only are going to engage with, but really just have some longevity to them. And so I would say that with the tools available to us through anthropology and through decolonization theory, in our program we created space for overtly indigenous programming in a way that other disciplines and even non-native practitioners can miss. And they miss them because too often they privilege kind of theoretical abstraction and decontextualize data over the richness and feeling of culture or the lived experiences of our community and our community members. When we as an agency made the choices, when we did what we wanted to do in the way that we wanted to do it, we achieved results and continue to have results that impact the lives of our kids, our families, and our communities. And that's really what we want to do as a program. We want to be community-centered and community-first. And so with that, I have concluded my presentation.
Thank you very much, Kerry. At this time, we'll go ahead and start taking some questions. If anybody had any questions that they wanted to ask Kerry, go ahead and feel free to write them into the question log there. I'm working on trying to open this one up here. This person says, thanks for a fabulous presentation. What do you do with the adult smokers when their children give them a hard time about smoking? Do you offer stop smoking assistance? Very exciting that you have success in deferring youth initiation of smoking. That will go a long way for a ceremonial versus addictive use.
Okay, so yeah, when myself personally, I try to respond to everything with a little bit of humor, especially when parents are really annoyed with me because their kids are saying something that counters what they believe. I mean, we definitely offer sort of the we have the stop smoking, we refer people to quit line, we've got nicotine patches, and we have all of that kind of stuff. But because of how we choose to run our program, that also gives us the opportunity to kind of invite the parents to be a part of the programming that we do with the kids to help them to kind of counter some of their beliefs and their kind of misperceptions about tobacco use. And in Lumbee communities, that's kind of difficult because they are tobacco growers. But I've even brought my Chinoopa in to talk with folks about. And so when they get to understand a different way of thinking about tobacco, or how tobacco is used oftentimes more not smoked but placed and offered than actually being ingested, or thinking of tobacco as a medicine, it doesn't completely stop their use, but it can slow it down, and it also has made them sort of more respectful about what they do in our area, because we do have signs at the front of our building, saying that we respect tobacco as a medicine, and and we don't condone non-ceremonial use of tobacco here. And so at least in that short term, it makes a difference, and I hope at least it may change their thinking, and they may think twice about that. This is something hopefully that longitudinally we'll know, and as an anthropologist, I think really long term. But yeah, that's how we address that.
Great. And then we've got a couple other comments saying thank you for the webinar, and saying that it was a very wonderful webinar. If anybody has any other questions, feel free to go ahead and put them into the question box. We'll keep it open for about another couple of minutes here. This person says, can you talk a little more about about the safe spaces you create for Native families. What kind of education or discussions happen regarding historical trauma? Are mental health services available in your organization? How do you engage and or manage adults who are active in SUD?
Okay. So we, again, at every level of our programming, I would say probably with the exception of our dental services, again, culture is really at the foundation of that. So we do have a behavioral health program. We have a medical anthropologist as well as a licensed clinical professional counselor here who sees clients. Most of our clients are in active substance abuse, and so we can have a really, it's an interesting mix that we see the parents of the kids that we see on Thursday nights, we see their parents during the day for the different groups that we run, or the one-on-one sessions. So for example, we started doing a seeking safety program for women who were survivors of trauma. But that model, because it was a non-native model, didn't really fit well for them. So we started using the Journey Woman model, which I think comes out of the Choctaw tribe. But examples of the way that we create safe space and bring culture into that type of programming, we participated in the Walking with Our Sisters project. So we had people beading vamps to moccasins. We did other type of beadwork, and that was a great way for the women to kind of engage in a traditional activity and one that was of value to them, but also talk about their experience of trauma and abuse and substance abuse that would otherwise be difficult for them to talk about. And again, it replicates the ways that we as Native women might be going about our work and just having conversation with our sisters, our aunties, our grandmas. We participate in a lot of public activities. So we did the Sing Our Rivers Red project. We did the Monument Quilt, which looked at survivors of sexual assault. And so the adults in our community were able to create art or create quilt squares that not only allowed them to talk about their own trauma, but also put them in the unique position, and a position they don't often find themselves in, where they are able to offer support to other people, and they see how their experiences are connected to other experiences in country. So that creates that cultural space for them, and I hope that answers that question.
Excellent. We have another question here. It says, concerning historical trauma, we're told that happened in the past, just get over it. I consider telling those who see it that way to stand and tell returning soldiers who have PTSD, it happened over there in the past, just get over it. Is there a better way to get people to understand that historical trauma really does still have effect on many of us?
I would say that the things that are happening right now in Standing Rock, and my nephew was one of the folks that got arrested out there, shows that it didn't ever stop. The fact that a football team can use a demeaning name for our people, and that has more authority than what we say, shows that it's not over. So you can't get over something that hasn't stopped happening. I was giving a talk once, and I was asked that question, and I said, would anyone tell Elie Wiesel, the Holocaust survivor, would anybody tell him to get over that? And those people have different reactions to those kind of analogies, but I think they are very useful, because that's the other function of the historical trauma, or the microaggression, that people don't see Native people as living contemporary human beings, that we only exist in the way that they understand us in Dances with Wolves or on their TV screen. And so I think sometimes they're tempted to think of us as less human. This may be a dramatic way to answer the question, but someone once asked me, well, are you ever really called Pocahontas? And I told him very truthfully that one of the men who raped me called me Pocahontas while he was doing so. And again, that maybe I was being a jerk. I mean, it's a true story, but maybe I was being too blunt. But I also don't feel like we do ourselves or settlers any favors by sugarcoating things for them. And I think we as Native people shouldn't always feel like we have to be polite and kind of tap dance for the settler gaze or do things to make them comfortable. I think, we have to do what's right for us, and we have too long been denied voice, and we have to use our voice in a way that is real and true and powerful.
This other person asks, as you know, NREPP does not provide any EBPs for Native people, and SAMHSA struggles to support culturally specific programming for study. Are you engaged in any documentation of culturally validated practice?
I, as an individual anthropologist, definitely do publish. I present more than I publish, and I joke that it's because I come from an oral culture, but really I hate writing, and that's the truth. So, I do publish, I do participate in conferences as a NCUI member. I participate in the annual conference, the leadership conference, and members of SAMHSA come there. So, based on our kind of last two leadership conferences, SAMHSA was really doing a better job about thinking of best practices versus EBPs, and I think the Circles of Care grant, kind of reflect that. So I think in terms of all of the other funders, SAMHSA is the better bet. But yes, I mean, we do publish, I think, because of our proximity to NCUI, we participate in events with them where we interface with different government agencies as often as possible, have them visit us. So I think that's the way that we're trying to help and move the way of thinking towards best practices or what works for Indian country versus what works for the funder. Who knows what'll happen.
Excellent. Got a couple of compliments. Thank you. Another person said, thank you for sharing yourself with us so we might learn and move forward in life. We'll keep things open for about another minute or so, see if there's any other questions that happen to pop in here. If you happen to have questions, feel free to go ahead and put them into the question box. Otherwise, we'll go ahead and mention that you can follow the National Native Network online. Go to www.keepitsacred.org. We're going to have the webinar archived up on the website, and you'll also be notified of that if you follow us on social media. Follow us on Facebook.com/keepitsacred. Follow us on Twitter @keepitsacred, and then we're also on LinkedIn at bit.ly/keepitsacred. This other person says, could you speak to the resources on the resource page, one of the handouts that were uploaded onto GoToWebinar?
So again, I outed myself as an academic, and they are primarily that. I'm sure that, we could make other resources available. For me, as an applied anthropologist, so when you get outside of academia, they kind of gatekeep, and even though they expect you to keep up with your peers, they don't allow you access. So I'm a big fan of open access media. Journal of Decolonization is one of my favorite places to look for peer-reviewed articles that are written by indigenous scholars, because I think that's really important. And Joe Gahn does a really good job of making his publications available. But Pamela Jumper-Thurman, I think she was with CASE, and that was an HIV prevention program. That stuff was available online. So, the resources that I provided, again, were really biased towards kind of theoretical ways of looking. I think one of the Braveheart articles and maybe one of Karina Walters' articles talked about models that you could use, and definitely the Jumper Thurman and Vernon article looked at the way they work with women in doing HIV prevention. So if you find models that you like, then you can kind of plug in the issues that exist in your community, and they're good kind of frameworks for setting that stuff up.
Excellent. Well, with that, I think we're going to wrap things up for today. Again, make sure that you follow us on social media, facebook.com/keepitsacred, twitter.com/keepitsacred, and follow us on LinkedIn, bit.ly/keepitsacred. We'll have the webinar uploaded and archived on the website by close of business Wednesday afternoon. And we'll also be sending out the survey within the next 24 hours or so in order to get some feedback on the webinar, and that'll be, we'll need that in order to do the continuing education units for everybody as well. Again, thank you very much, and I hope everybody has a very happy Halloween and a wonderful Monday. Thank you very much. Bye-bye.